The operating room at Cleveland Clinic fell silent except for the rhythmic hiss of the ventilator. May 9, 1967. A 51-year-old woman lay open on the table, her heart exposed and struggling. René Favaloro studied the coronary arteries, their blockages visible through the surgical field. Standard procedures had failed this patient. Medication couldn't reach tissue starved of blood. Conventional surgery couldn't clear arteries choked with decades of plaque. Favaloro reached for a segment of vein, harvested from the patient's leg. His plan seemed almost absurdly simple: sew one end above the blockage, the other below, creating a bridge that would carry blood around the obstruction. A detour through the patient's own tissue. In the observation gallery, senior surgeons watched with skepticism. This Argentine country doctor was about to attempt something unprecedented, building a bypass around death itself. René Favaloro was born on the 12th of July, 1922, in La Plata, capital of Buenos Aires province, to Italian immigrant parents who had crossed the Atlantic seeking opportunity in Argentina. His father worked as a carpenter and cabinet maker, building furniture with the precision that René would later apply to blood vessels. His mother managed the household with the resourcefulness that poverty demanded. The family lived modestly in a neighborhood where Italian remained the first language and Old World traditions mixed with New World ambitions. The person who shaped René's path most profoundly was his paternal grandmother, Ces Ferreira Stefanelli. She worked as a partera, a traditional midwife, moving through La Plata's working-class neighborhoods, delivering babies and treating ailments that families couldn't afford to bring to doctors. Young René accompanied her on calls, watching her hands work with practiced confidence, learning that medicine happened wherever suffering existed, not just in sterile hospitals. She taught him that healthcare was a human right, not a luxury reserved for those who could pay. The 1930 Depression hit Argentina hard, collapsing export markets and triggering political instability that would plague the country for decades. René grew up watching families lose everything, understanding viscerally how economic forces could destroy lives as surely as disease. Education became his family's investment in a future that seemed increasingly uncertain. He excelled in school, drawn particularly to science and the concrete logic of problem solving. At 18, René entered the University of La Plata's medical school. The training followed European models, emphasizing theoretical knowledge and clinical observation. Professors taught accepted techniques and discouraged questioning established methods. René learned anatomy, pharmacology, surgical procedures, absorbing the foundation of medical practice while quietly noting its limitations. The curriculum prepared doctors to treat diseases they understood, using tools already invented. It didn't prepare them to innovate. He graduated in 1949 with his medical degree, joining his brother Juan Josfi, who had become an anesthetist. The brothers could have established comfortable practices in La Plata, treating middle-class patients in proper facilities. Instead, they chose a different path. News had reached them of Jacinto Aráuz, a remote farming community in the Pampas, desperately needing doctors. The town offered no hospital, no modern equipment, no comfortable future. It offered only need. For René Favaloro, shaped by his grandmother's example and his family's values, that was enough. Jacinto Aráuz sat in the middle of nothing, 400 kilometers west of Buenos Aires, where the Pampas stretched flat and endless. The town held 3,500 people, most working farms that produced wheat, corn, and cattle for distant markets. When the Favaloro brothers arrived in 1950, the community had no hospital, no surgical facilities, no infrastructure for modern medicine. Serious cases traveled hours to larger cities, often dying en route. Minor emergencies became major ones through neglect. The town had made do with visiting doctors and folk remedies, accepting that rural life meant rural death rates. René and Juan José transformed a modest building into a clinic, improvising solutions for everything they lacked. Kitchen tables became operating theaters. Farmhouses turned into recovery rooms. René performed appendectomies, cesarean sections, hernia repairs, and countless other procedures under conditions that would horrify medical school professors. Juan José administered anesthesia with equipment. They'd scrounged or built themselves. They treated snake bites, farming accidents, infections, difficult births, everything that could go wrong with human bodies, far from help. The isolation forced creativity that urban hospitals would never demand. Without specialists to consult, Rene studied medical journals and textbooks by lamplight, teaching himself techniques outside his training. Without proper diagnostic equipment, he learned to read symptoms with exceptional precision. Without pharmaceutical options, he discovered which traditional remedies actually worked. The constraints didn't limit his practice. They expanded it, pushing him to see medicine differently than doctors who worked within comfortable systems. The brothers charged what patients could afford, which often meant nothing. Farmers paid in chickens, produce, or labor. Some paid nothing at all, and the Favaloros treated them anyway. Rene's grandmother had taught him that healthcare was a human right. Jacinto Aráuz reinforced that lesson daily. He saw how poverty and geography conspired to deny people the care that would be routine in cities. The unfairness gnawed at him, shaping convictions about medical ethics that would define his later career. For 12 years, from 1950 to 1962, René Favaloro practiced medicine in Jacinto Aráuz. He became one of Argentina's rural doctors, the physicians who served remote communities with skill and dedication, but little recognition. He could have spent his entire career there, respected locally and unknown elsewhere. But medical journals arriving from the United States brought news of breakthroughs in cardiac surgery. Doctors were opening hearts, repairing valves, correcting congenital defects. The reports fascinated Rene, particularly work on coronary arteries. At 40, he made a decision that seemed reckless to colleagues in Argentina. He would leave his established practice and start over as a student. Cleveland Clinic in 1962 stood at the forefront of cardiac surgery, one of the few centers where doctors routinely opened human hearts and expected patients to survive. René Favaloro arrived speaking minimal English, leaving behind 12 years of practice for a fellowship position that offered no guarantees. His credentials, medical degree from Plata, rural surgery experience, meant little in American academic medicine. He was 40 years old, starting over in a foreign country, learning a language while learning techniques that were themselves brand new. He joined the team led by Donald Effler and Mason Sones, surgeons who had pioneered coronary angiography. Sones had developed a technique for threading catheters into the heart and injecting contrast dye, making coronary arteries visible on X-rays for the first time. The breakthrough transformed cardiology from educated guessing to precise visualization. Doctors could finally see exactly where arteries narrowed or blocked, watching blood flow struggle through vessels choked with atherosclerotic plaque. The imaging revealed the problem with unprecedented clarity. It couldn't fix anything. Favaloro studied existing surgical approaches to coronary artery disease with growing frustration. Endarterectomy involved opening blocked arteries and scraping out plaque, a procedure that often caused more damage than it repaired. Patch grafts could widen narrowed sections but couldn't address complete blockages. Medication managed symptoms without treating underlying obstructions. Heart attacks remained largely untreatable events that killed some patients and severely damaged others. The standard approach was managing consequences rather than preventing them. The solution seemed obvious to Favaloro, perhaps because his rural practice had taught him to think around obstacles. If an artery was blocked, don't try to clear it, bypass it. Build a detour using another blood vessel, creating a new path that circumvented the obstruction entirely. The concept wasn't completely original. Surgeons had attempted various bypass approaches with limited success. But Favaloro saw possibilities others had missed, particularly in his choice of graft material. His colleagues at Cleveland found the Argentine fellow peculiar. He worked constantly, studying cases with an intensity that suggested he was compensating for starting late. He asked questions that seemed naive, challenging assumptions experienced surgeons had stopped examining. Why not use the saphenous vein? Why not create complete bypasses instead of partial repairs? The questions irritated some senior surgeons who heard criticism of their methods. Others recognized something valuable in this outsider's perspective. Favaloro hadn't been trained in Cleveland's traditions. He wasn't invested in existing approaches. He could see the problem fresh, asking what would work rather than what was already tried. The saphenous vein runs the length of the leg, carrying blood from the foot back toward the heart. Most surgeons considered it unremarkable, a vessel notable mainly for becoming varicose when valves failed. Favaloro saw it differently. The vein was long, providing enough material to reach anywhere in the heart. It was expendable. The leg had deep veins handling most return flow, making the saphenous largely redundant. It was the patient's own tissue, eliminating rejection concerns that plagued attempts using synthetic materials. The vein was the answer hiding in plain sight. Through early 1967, Favaloro experimented with coronary surgery techniques at Cleveland Clinic. He began conservatively, using segments of saphenous vein as patches to enlarge narrowed arteries. The patches worked but addressed only limited blockages. He progressed to more ambitious grafts, creating partial bypasses that augmented blood flow without fully replacing blocked paths. Each procedure taught him about the mechanics of grafting, how veins responded to arterial pressure, how to anastomose vessels to minimize turbulence and clotting. On May 9, 1967, Favaloro performed the operation that would define his career. The patient was a woman with severe coronary disease. Her right coronary artery almost completely occluded. Previous interventions had failed. Medication provided minimal relief. She faced progressive heart failure and likely death. Favaloro harvested a segment of saphenous vein from her leg, then attached one end to the aorta and the other to the coronary artery beyond blockage. Blood flowed through the new path, bypassing the obstruction entirely, delivering oxygen to tissue that had been starving. The patient survived. More importantly, she improved. Her angina diminished. Her heart function recovered. The bypass worked exactly as Favaloro had predicted. He documented the case meticulously, but didn't immediately publish. One success meant nothing scientifically. It could have been luck or an anomaly. He needed to prove the technique worked consistently across different patients and blockage patterns. Over the following months, Favaloro performed more coronary artery bypass procedures, refining his technique with each operation. He learned to select appropriate patients, to identify which blockages were amenable to bypass, to manage the technical challenges of working on a beating heart. Some patients required single bypasses, others needed multiple grafts, creating several detours around several blockages. The operations were lengthy and demanding, requiring precision measured in millimeters, but they worked. Patients who had been declining improved. Those facing death survived. By 1968, Favaloro had accumulated enough cases to publish. His paper in the Journal of Thoracic and Cardiovascular Surgery described the technique and early results. The response from the surgical community mixed skepticism with cautious interest. Other surgeons attempted the procedure with varying success, discovering that coronary bypass demanded technical skill and judgment that couldn't be learned from articles alone. René Favaloro understood that individual successes meant nothing without systematic validation. Medical history was littered with promising techniques that failed when widely adopted, procedures that worked for their inventors, but proved unreliable in other hands. He couldn't just demonstrate that coronary artery bypass grafting could work. He needed to prove it worked consistently, that outcomes justified the risks, that other surgeons could learn the technique and replicate his results. He approached documentation with the same rigor he brought to surgery. Every case was recorded in detail: patient history, angiographic findings, surgical approach, post-operative course, complications, long-term outcomes. He tracked which blockage patterns responded best to bypass, which patients benefited most, which technical variations produced optimal results. The data accumulated week by week, operation by operation, building an evidence base that transformed individual observations into scientific conclusions. In 1969, Favaloro published comprehensive results in the Annals of Thoracic Surgery, presenting outcomes from 137 patients who had undergone coronary bypass procedures. The numbers told a compelling story. Most patients experienced significant improvement in angina symptoms. Angiographic follow-up showed grafts remaining patent, continuing to deliver blood around blockages months after surgery. Mortality rates, while not zero, compared favorably to the natural history of severe coronary disease. The paper provided what skeptics demanded, evidence that bypass surgery offered genuine therapeutic benefit. The surgical community's response shifted from skepticism to serious interest. Cleveland Clinic began training visiting surgeons in bypass techniques. Favaloro became an unlikely teacher, the former rural doctor from Argentina, instructing American and European surgeons in methods he had developed. He emphasized that coronary bypass was not a simple procedure. It required understanding coronary anatomy, skill in vascular surgery, judgment about patient selection, and careful post-operative management. Surgeons who rushed to adopt the technique without adequate preparation saw poor results. Those who trained properly and worked systematically achieved outcomes matching Cleveland's. By 1970, coronary artery bypass grafting was spreading worldwide. Centers in Europe, Asia, and South America established cardiac surgery programs based on Favaloro's methods. The technique evolved as surgeons contributed refinements. Some used arteries instead of veins for grafts. Others developed approaches for operating on still hearts using cardiopulmonary bypass. The fundamental principle remained Favaloro's: when the primary path fails, build an alternative route. The revolution extended beyond technical innovation. Coronary artery bypass transformed how medicine approached heart disease. Before bypass surgery, heart attacks were events to be survived or not, with doctors managing consequences after the fact after bypass. Coronary disease became a condition that could be treated preemptively. Patients with severe blockages discovered through angiography could undergo surgery before heart attacks occurred, preventing damage rather than repairing it. The shift from reactive to preventive care saved lives and redefined cardiac medicine. In 1971, at the height of his success at Cleveland Clinic, René Favaloro made a decision that baffled his American colleagues. He announced he was returning to Argentina to build a cardiac institute that would serve everyone, regardless of their ability to pay. Friends asked why he would abandon the world's premier cardiac surgery center, where he had access to unlimited resources and the best collaborative environment in the field. Favaloro's answer reflected convictions formed in Jacinto Aráuz and reinforced by his grandmother's example. Healthcare was a right, not a commodity, and Argentina needed what he could build. Argentina in the early 1970s was a country lurching between military dictatorships and fragile democracies, its economy cycling through inflation and crisis. The healthcare system served those with money or connections while leaving much of the population with inadequate access to specialized care. Cardiac surgery existed in major hospitals, but remained limited, expensive, and available primarily to wealthy patients. Favaloro envisioned something different, an institution combining research, treatment, and training at international standards while treating patients regardless of their financial circumstances. The Favaloro Foundation opened in Buenos Aires in 1975, after years of planning and fundraising complicated by political instability. The institute included operating rooms equipped to Cleveland standards, research laboratories, and a residency program designed to train the next generation of Argentine cardiac surgeons. Favaloro recruited colleagues from Cleveland and other international centers, building a staff capable of performing the most advanced cardiac procedures available anywhere. The financing model reflected Favaloro's idealism and pragmatism in equal measure. Wealthy patients paid full fees for treatment, effectively subsidizing care for those who couldn't afford it. The foundation sought government support, though Argentina's political instability made such funding unreliable. International donations supplemented income from paying patients. Favaloro invested his own money, channeling income from his growing international reputation into keeping the foundation operational. The approach worked, but left the institution perpetually vulnerable to economic shocks. The foundation quickly established itself as Latin America's premier cardiac center. Surgeons came from across South America for training in bypass techniques and other advanced procedures. Research programs investigated questions specific to regional populations. Poor patients who would never have access to cardiac care received treatment identical to what wealthy patients received. Favaloro performed surgery, taught residents, directed research, and managed the institution's precarious finances, working schedules that would have broken younger physicians. His colleagues marveled at his energy and worried about his judgment. He could have remained at Cleveland secure and celebrated, performing surgery without worrying about budgets and politics. Instead, he had chosen to fight Argentina's endemic problems while trying to deliver world-class healthcare. The choice seemed quixotic to practical observers. To Favaloro, it was the only choice his values allowed. Running a world-class cardiac institute in Argentina proved far more difficult than developing coronary bypass surgery. Favaloro had solved a technical problem through innovation and skill. The foundation faced structural problems that no amount of skill could overcome. Argentina's economy cycled through crises with depressing regularity. Inflation eroded operating budgets. Currency devaluations made imported equipment and medications prohibitively expensive. Government support appeared and vanished with regime changes. The foundation survived month to month, sustained by Favaloro's international reputation and his personal resources. The insurance system presented endless frustrations. Companies contracted to reimburse the foundation for treating their policyholders, then delayed payments for months or years. Bureaucratic obstacles multiplied. Favaloro spent increasing time fighting for money already owed, chasing payments, while trying to maintain clinical and research programs. The contradiction grew starker. He was internationally famous, nominated repeatedly for the Nobel Prize, honored by medical societies worldwide. While struggling to keep his institution solvent, his fame became a double-edged instrument. International speaking engagements brought income that subsidized the foundation but pulled him away from Buenos Aires. He published books about bypass surgery, about medical ethics, about healthcare as a human right. The publications enhanced his reputation but didn't solve the foundation's fundamental problem: delivering expensive care to populations with limited ability to pay in an economy that made long-term planning impossible. Through the 1980 and 1990, Favaloro poured personal resources into the foundation, using income from international activities to cover operational shortfalls. He refused to compromise on care quality or turn away patients who couldn't pay. The foundation continued treating everyone, performing thousands of cardiac procedures annually, training hundreds of surgeons, publishing research that advanced the field. But the debt accumulated, month after month, year after year, as expenses exceeded income and insurance companies delayed payments that might have closed the gap. The stress showed in ways colleagues noticed and worried about. Favaloro remained passionate about medicine and teaching, still performing surgery with precision and joy. But conversations increasingly turned to frustration about Argentina's healthcare system, about institutions that promised support and delivered nothing, about insurance companies treating the foundation's work as a commodity to be paid for at convenience. Friends urged him to reduce the foundation's scope, to limit services to what funding could sustain. He refused. Compromising meant abandoning patients. That wasn't acceptable. By 2000s, the foundation owed millions to suppliers, staff, and creditors. Insurance companies owed the foundation even more, but collecting those debts seemed increasingly unlikely. Favaloro was 76, still working exhausting schedules, trying to hold together an institution that economic reality seemed determined to destroy. The man who had built detours around blocked arteries couldn't find a detour around insolvency. The 29th of July, 2000s, started as a Saturday like others at the Favaloro Foundation. Rene arrived early, as always, reviewing cases and checking on post-operative patients. He spoke with residents about surgical techniques, offering guidance refined through decades of experience. Colleagues noticed nothing unusual in his manner. He seemed tired, perhaps, but tired was his normal state after years of carrying the foundation's burdens. Around midday, Favaloro left the foundation and drove to his apartment in Buenos Aires. He had lived simply despite international fame, in a modest residence that reflected his priorities. Money earned went to the foundation, not to personal luxury. He entered his apartment alone. In the bathroom, Favaloro removed a pistol and placed it against his chest. The location seemed deliberate to those who learned the details later. A cardiac surgeon shooting himself in the heart he had spent a lifetime protecting, a single shot. He collapsed and died. 77 years old, the man who had saved millions unable to save himself. He left behind letters explaining his decision. The foundation faced bankruptcy with debts approaching $75 million. Insurance companies owed the foundation comparable amounts, but showed no urgency in paying. Suppliers were threatening legal action. Staff hadn't been paid consistently. He saw no solution, no path forward that didn't involve betraying the mission he had built his institution to serve. The letters expressed despair and anger in equal measure, despair at his personal failure to sustain the foundation, anger at a system that valued profit over human life. The news shocked the medical community worldwide. Colleagues who had worked with Favaloro in Cleveland and Buenos Aires struggled to understand how someone so accomplished could reach such desperation. The story forced uncomfortable questions about healthcare economics, about the sustainability of idealism in systems designed around different principles, about what society owed physicians who sacrificed personal well-being for patients' benefit. Argentina responded with soul-searching and recrimination. The government, which had promised support and delivered little, expressed sorrow. Insurance companies, which owed millions, claimed financial and regulatory constraints. The foundation's creditors, facing their own financial pressures, offered sympathy but needed payment. Everyone mourned. No one accepted responsibility. The foundation survived, reorganized and refinanced through emergency measures. Favaloro's death became the crisis that forced action from institutions that had ignored escalating problems while he lived. The irony was bitter. His suicide accomplished what his appeals for help couldn't. The cost was a life that heart disease had never managed to claim. Coronary artery bypass grafting became one of the most frequently performed operations in modern medicine. Hundreds of thousands of procedures occur annually worldwide, each one tracing back to May 9, 1967, when René Favaloro sewed a length of vein around a blocked artery in Cleveland. The technique evolved beyond what Favaloro pioneered. Surgeons use arterial grafts, perform operations on beating hearts without cardiopulmonary bypass, employ minimally invasive approaches through small incisions. Drug-coated stents offer alternatives for some blockages, but the fundamental principle endures. When the primary path fails, build an alternative route. The lives saved number in the millions. Patients who would have died from heart attacks in the 1960s now survive because surgeons can bypass blockages before infarctions occur. The detour Favaloro invented transformed coronary artery disease from a death sentence into a manageable condition. His legacy appears in every bypass patient walking, working, living decades beyond what previous generations could expect. The Favaloro Foundation continues operating in Buenos Aires, fulfilling the mission its founder died trying to protect. The institute treats thousands of cardiac patients annually, trains surgeons from across Latin America, and maintains research programs advancing cardiac care. The work continues, though the man who built it couldn't witness the survival. René Favaloro's story remains incomplete, a genius who solved death from heart disease, but couldn't solve the economics of compassion.